shown that, yeah, you're right, it's great. Our next speaker is Gina. You're in a hurry. Is Gina Choi at UCLA. You all know Gina. She's been here many times before. She has a keen interest. She's a transplant hepatologist at UCLA, has a keen interest in pregnancy and liver disease, and she's going to update us on that. Thank you.
Hello, good morning. I also talk very quickly. And if you're thinking what I'm thinking, lunch is in 1 hour. Okay, so really quickly, so we're going to talk about liver disease in pregnancy. These are my disclosures, which are not related to the talk today. So quickly, we're going to go over how to recognize liver disease in pregnancy, some common liver diseases that are unique to pregnancy, and management of pre-existing liver diseases that we find in pregnancy, including viral hepatitis, autoimmune liver disease, and cirrhosis. So just a brief outline here. So we have chronic liver disease that all women can certainly have. That viral hepatitis, autoimmune disease, fatty liver, alcohol, the metabolic liver diseases. And then there are certain liver diseases that are unique to pregnancy. Hyperemesis gravidarum, which I will not be talking about, preeclampsia, HELP, intrahepatic cholestasis of pregnancy, and the dreaded acute fatty liver of pregnancy. So while pregnancy-related severe liver disorders are rare, when they occur, the morbidity and mortality is pretty high. So this study was a study from the US that looked at 41 million pregnancies. And we found that gallbladder disease or biliary disease was the first most common at 7.1 per 1,000 pregnancy hospitalizations. And the second most common was 4.65 per 1,000 pregnancies for people who had acute liver disorders of pregnancy. This kind of gives you a sense of how many people are suffering from this. So what's normal? So normal physiologic changes in pregnancy include low albumin, low hemoglobin. The pathophys is dilutional in that sense. And of course, an elevated alkaline phosphatase and AFP, which is produced by the placenta. But any abnormalities in AST, ALT, or bilirubin are not normal, and they absolutely warrant further evaluation. So when you look at a pregnant patient with abnormal liver disease, you kind of have to do the standard workup as with any non-pregnant related individual. And when you think about it, it's like pattern recognition and also gestational age. So this was taken from the guidelines. And if you have abnormal liver tests, on the left side, you have cholestatic patterns of liver disease. On the right side, you have AST, ALT, hepatocellular patterns. In the middle here, you see what are unique to pregnancy. So we have these little boxes that we think about, AST, ALT, patterns, but then there's also things that we could think about from a trimester approach. So all through pregnancy, these are the chronic liver disease that I talked about in my first slide. You can also have these situations in the first, second, third. For hyperemesis gravidarum, you see in the first trimester. For intrahepatic cholestasis of pregnancy, second and third. And of course, preeclampsia and HELP and acute fatty liver in the later stages. So since we talked about how common gallbladder disease is, and you think about how common that is in women with pregnancy, I just want to review what is safe in terms of imaging modalities. So ultrasound without Doppler, bingo, very safe in pregnancy. An MRI without contrast is also safe in pregnancy. With contrast, you do not want to use gadolinium because it's actually taken up by the fetal kidneys and re-excreted into the amniotic fluid. So a lot of exposure there. A CT without contrast, but an MRI is better without contrast because of the minimal amount of radiation. And a CT with contrast, yes, but only if absolutely essential. So about gallstones, you did the ultrasound with duplex, without duplex, you found the gallstones. And so why is this so common? Because the hormonal changes lead to decreased gallbladder motility and lithogenic bile. Risk factors include high pre-pregnancy BMI. It actually occurs up to 10% of pregnancies, which is a lot, but the incidence of complications is only 0.5 to 0.8%. We discussed ultrasound as the imaging of choice, and if they're symptomatic, you can do a lab chole and an ERCP, safest in the second trimester. What you really want to avoid is pancreatitis, which can cause fetal demise. So intrahepatic cholestasis of pregnancy, often the women get itchy before they get jaundiced. Risk factors include multiple pregnancies, fertility treatments, and genetics. Sometimes the AST and ALT can get really high, but it hasn't been shown to be associated with outcomes. Typically normal bili and GGT, so you really want to check the bile acids. So if it's greater than 10, you have a diagnosis. If it's greater than 40, you're kind of in big trouble. And you can also see cholic acid levels that are high in chenodeoxycholic folic acids, which are low. That just comes automatically on the panel, those 4 tests. So let's say you have a patient who has these recurrent episodes, right? So if they have earlier recurrent intrahepatic cholestasis of pregnancy, you can consider testing for this. Unfortunately, the prevalence in Caucasian patients is only to be 16%. But if you have a woman who's coming in with a lot of episodes of this, you can go fancy and check these fancy genetic tests. So in terms of management, you and the OB-GYN person will be checking weekly bile acids. Fortunately, 75% do respond to URSO. You want to deliver early at 37 weeks. And after they deliver, you want to make sure that everything gets better and advise progesterone-based contraception. So we're going to now go to just the chronic liver diseases that we see in pregnancy, so viral hepatitis B and C. So C is really cool lately. There's been a lot of stuff about this in the literature. Here, this is a slide that shows you the rate of hep C among pregnant women per 1,000 live births by state. It is from 2014, but even then we are seeing that the national rate was 1 in 308, and that was an increase of 89%, and there was substantial state-to-state variation. We know that with the PWID phenomenon, we see this highest in states like West Virginia and Wisconsin, and the lowest in Hawaii. This is an estimated prevalence hep C RNA positivity among women, pregnant women by state, and I circled California for you on the bottom. It's interesting because now they're recommending universal checking for hepatitis C antibody, but back then we only recommended in high prevalent areas, which was considered 0.1%. So this paper was just published in 2022, and they just talked about the consequences of maternal viremic HC infection. So this was a population-based retrospective study. It was actually done in Canada. They identified 1,700 hep C RNA positive pregnancies and 390 negative pregnancies. And they had a lot of interesting outcomes. So number one, they said, okay, how many of these women are actually getting appropriately tested for hepatitis C? And there's only 30%. Which is low. And then they found, okay, well, how many of these women are passing hep C to their babies? And they found that it was 3.5%. And they also actually found that if the RNA was greater than 1 million, the odds ratio was as high as 3.3%. They also found that there were certain adverse pregnancy outcomes like gestational diabetes, intrahepatic cholestasis of pregnancy. And they also found that the odds ratio for an increased risk of intrahepatic cholestasis of pregnancy was 4.55. So this is a little bit of an older paper that was a systemic review of 109 studies, and they split it up by HIV negative and HIV positive mothers, and they found that the risk of vertical transmission was 5.8. So if you look at the old study, the new study from the slide before, and this study, it's anywhere from 3.5 to 5.8%. So what is the take-home message from all this stuff? So I think it's important to check your pregnant women for hepatitis C, and that there's that they should get care, and that if a HCV-infected mother presents with pruritus of jaundice, your pre-test probability for intrahepatic cholestasis of pregnancy should be very high, and that they should be counseled extensively that, hey, if you have hepatitis C, there are certain adverse maternal and perinatal outcomes that you have to think about. Okay, so in summary, there is no known intervention to reduce risk of vertical transmission. They don't recommend C-sections, but they do recommend avoiding fetal monitoring, prolonged rupture of membranes, and episiotomy, and they do not discourage breastfeeding if you are hep C pregnant mom. Okay, and then so the real take-home message, though, is that you should treat hep C positive women who are reproductive age before pregnancy is considered, and that we do not recommend hep C treatment during pregnancy due to lack of safety and efficacy data. Okay, so we're going to switch gears now to hepatitis B. So it's kind of interesting. So a long time ago, I mentioned how you used to just check based on your risk factors. Now everyone should be checked. And then what's different about B is that you're trying to prevent transmission of hepatitis B to the child, right? So we don't have any tools in our inbox for patients with hep C, but we do have them for hepatitis B. They should also receive HBIG and vaccination within 12 hours of birth, but we really want to prevent the vertical transmission. So why do we want to do that? Because we know that preventing hep B at birth is so important because when you're exposed as a baby, you have a 95% chance of being chronic Hep B. If you're exposed as an adult, you only have a 5% chance of being chronic Hep B carrier. And we know that the DNA is very important, right? So what's mom's DNA at the time of birth? And the higher the DNA is, the more likely that you're going to get Hep B as a baby. So how do you prevent maternal to child transmission? So first trimester, you should check Hep B DNA replication, right? And you also kind of get a sense of how advanced their liver disease is. For example, it says here, check HBV DNA level near end of second trimester. And I actually hit this problem when I was a young attending. If the mom's DNA is 170 million, and you start treatment, you have a very short window of time to decrease the DNA to less than 10 to the sixth, right? That's why you want to check in the first trimester so you know kind of what you're dealing with. If the DNA is greater than 200 IUs per ml, then you want to start TDF. That's 300 milligrams a day between 28 and 32 weeks. And you could actually stop at the time of delivery, or you can continue up to 3 months after delivery. They've done studies with both. And if they are less than 200,000, then you want to monitor ALT and HBV DNA every 3 months for 6 months after delivery. Okay, so a lot of us are using TAF nowadays. So the question is, well, you said TDF in the former slide, so what about TAF in pregnant women with chronic hepatitis B? This is a slide taken from the EASL, just 2022 by Zhang et al., and it was a multi-center perspective real-world analysis of the safety and efficacy of TAF and TDF in 207 pregnant Chinese women. The baseline characteristics of the TAF women on the left, there were 103 of them. One fell out because she was exposed to agricultural chemicals, so they actually intentionally terminated the pregnancy. But we see here that 0% had maternal to child transmission, and there was normal infant development according to the Chinese and WHO standards. On the right here, there's also a little picture about HBe antigen seroconversion rate for women treated with TAF, because we know that a lot of these women are positive E antigen, and you can see that just to kind of munch on. However, the TAF label has not been updated to say that it is safe in pregnancy. So according to the FDA, you have a lot of studies that show that it is safe and effective, however, not according to the label. All right, so autoimmune hepatitis and immune suppression. So AIH flares can occur anytime in pregnancy. Pregnant women should be continued on treatment. So don't stop their steroids, don't stop their azathioprine. The highest risk period is within 3 months after delivery. The literature says as high as a quarter. And the risk factors include not being on treatment, and of course, a shorter remission before pregnancy. So you want their labs to be stable for at least a year before you advise them on pregnancy counseling. This slide is just kind of a summary of the medications we use in our AIH patients, also in patients who are post-liver transplant because they want to have babies too. And generally the consensus from the IBD literature and from what we know, we continue steroids, we continue azathioprine, we continue tacrolimus. You know, there are controversial things about whether steroids can cause cleft palates. TAC and azathioprine can be associated with low birth weight and prematurity. The only absolute no is Myfortic and Cellcept. You know, especially for young transplant patients, if we say, please let us know when you have plans to have a baby so we can take you off MMF and Cellcept, and we actually recommend 2 types of contraception. So the last part is cirrhosis and pregnancies. So this is a paper that was just published in 2020. They talk about the rising rates of childbirth in women amongst cirrhosis, a 7 times increase from 2000 to 2016. And the etiology, unsurprisingly, of the cirrhosis is mainly NASH or NAFLD. And compared to the general population, 17% more women with compensated cirrhosis are having children, and 34% less in decompensated cirrhosis. And I think for the gastroenterologist, what's really important to know is that Varicose hemorrhage is the most frequent complication. It can cause up to a 20% maternal mortality. So you have to be brave. So you have to screen for varices. So if you want to do screening within 1 year prior to conception. So if they don't have varices, you can repeat the EGD in the second trimester of pregnancy. If there are small varices, you can consider a beta blocker. If they're large or medium, you want to do banding or beta blocker. If they have varices before, then it's like the standard guidelines for all our patients. No treatment if there's no varices, beta blocker if they're small, and of course banding till obliteration or beta blockers if they're large. You're probably wondering, well, is that safe for the baby? And there are rare reports of intrauterine growth restriction and neonatal respiratory depression and hypoglycemia, and there's no data for COREG. Okay, so conclusion. So elevation in ALT, AST, and bili must be investigated during pregnancy. Pregnancy-induced liver disease is uncommon, but prompt recognition is critical for appropriate management. You should screen everyone for viral hepatitis. I check the C antibody, surface antigen. I even check A antibody and make sure they're immune for all my patients. And pre-existing liver disease has an impact on pregnancy, pretty minimal with the exception of portal hypertension and immunosuppression. You may have noticed that I cheated and I did not talk about breastfeeding at all. I do want to draw your attention to LACMed. The primary care doctors love this. This and Liver Talks are my two most favorite liver-related websites. You can type in here any medication to see if it's safe to take or not while you're breastfeeding. I do want to draw your attention to 3 additional resources. A lot of this information was taken from the AASLD practice guidelines for reproductive health and liver disease that just came out about 2 years ago. And it's interesting because the AASLD is now putting out patient guidances for every guideline. So the one for women and liver disease is going to come out in January of 2023. And there's also a more patient-friendly clinical liver disease where they talk about autoimmune hepatitis and other various things that you can direct your patients to. That's it. Wow, I did talk really fast. Sorry about that.